Hello students, in this module we are going to discuss some important images as far as pediatrics is concerned. So before beginning this images based revision, I would like to you to see this. The eye sees what the mind knows. So your mind need to know something in a background before you interpret what you see in the image. Right? So it's very important that your theory is first clear. Then only you can appreciate what you are seeing in that particular image. Right, so we are going to go section by section. These images we have encountered here and there when we were studying in the main videos, but here we are just going to recap and revise what all we can grasp through that particular image. So without further ado, let's start this section. First unit from which we are going to discuss the images is the growth section. So in growth, anthropometry plays a very important role, and I have three images in front of me. Can you notice this image, image A? What is happening over here in this image A? A child is lying down on a scale, right? And weight is going to he's going to be weighed down, right? So this is a digital scale on which the child is lying, and we are monitoring the weight of the child. And we all know the weight of the child, the average birth weight in India is 3 kgs, and in the first 7 days there is physiological weight loss, and we all know this physiological weight loss is up to 10% in cases of term babies, and it is regained by day 10 of life, right? So this is about physiological weight loss and the pointers that you need to know. Let's look at the second image, image B. What is this image? Which anthropometric parameter I measure with this image? So this is nothing but an infantometer. We measure the length of the child. So we make the child lie down like this. So we have a fixed end. This is the fixed end. This is actually the head end. And then we have a mobile end. So I need two examiners to measure the length. One will stabilize the baby and the other will move this mobile hand to position. And we calculate the length of the child, the lying down length. The name says infantometer, and we all know infant is someone who is less than 1 year of age. But remember, this infantometer is used to measure the length till 2 years of age. Why we are measuring the length till 2 years of age? After 1 year, the child knows how to stand. We can take the standing length, that is the height of the child. Why we are still making the child lie down and measure the length? Because till 2 years of age, there is physiological bowing of legs. That can give me a false height, right? So because of the physiological bowing of legs, I use infantometer to measure the length till 2 years of age. After 2 years, finally we can take a height. And height, to measure the height, we use this device. Can you name this device? Yes, this is nothing but a stadiometer. This we are going to use after 2 years of age. This measures the height of the child, right? And remember, whenever we are measuring the height, the child should be standing erect. The buttocks should be in one line, feet should be touching the wall, and the child's head should be in the Frankfurt plane. So this is all about the anthropometric parameters. All of these parameters are age-dependent parameters. The weight, length, height, all of these are age-dependent parameters. Let's move on to the next age-dependent parameters. What we are doing over here? Can you see? We are taking a measuring tape and placing it over the head of the child. What we are doing? We are measuring the HC. What is HC? We are measuring the head circumference. Whenever we measure the head circumference by some measuring tape, where do we place this tape actually? We place anteriorly just above the supraorbital ridges, and posteriorly it should be on the highest point on occiput, and we overlap this here in this parietal region. So this is how we measure the head circumference. They ask what is the normal head circumference at birth of a term baby? It's 33 to 35 centimeters. Right, and how does it grow? A very important question. As far as Inicet is concerned, Fmge is concerned, Neet PG is concerned, the rate of increase in head circumference is a hot favorite question. So let's learn how head circumference grows post birth. So in the first 3 months of life, the rate of growth is 2 centimeters per month. In the next 3 months, that is from 3 months of the age till 6 months, it's 1 centimeter per month. And thereafter for the next 6 months, it's 0.5 centimeter per month. So 2 into 3, that is 6 centimeters in the first 3 months. 1 into 3, that is 3 centimeters in the next 3 months. And 0.5 into 6, that is again 3 centimeters in the next 6 months. So the total gain in the first year of life would be 6 plus 3 plus 3, which comes out to be 12 centimeters. So let's say I take that the birth circumference of a child was 34 centimeter. So after an year, 12 centimeters would be added. So at 1 year of age, the child's HC would be 46 centimeters. 46 centimeters. In the next 1 year now, the child gains just 2 centimeters. So by the end of 2 years, it is going to be 48 centimeters. Now, what are the pointers for the exam? They say, what about the birth circumference? This birth circumference is actually 60% of the adult size. And by the end of 2 years of age, we have reached 90% of the adult size. So these are some important questions for the next anthropometric parameter, that is head circumference. So all of these were age dependent parameters. Now let's talk about one age independent parameter, that is MUAC. What's that MUAC? So MUAC stands for mid upper arm circumference. Mid upper arm circumference. Why is this age independent parameter? Because in between 6 months to 5 years of age, when you take this mid upper arm circumference, initially the child is very chubby, right? So the child has a lot of fat that is included in that circumference. As the child grows, the baby loses that fat and gains muscle. So the overall circumference remains the same. So that's why it is labeled as an age independent parameter. This is how you measure the mid upper arm circumference. You take two bony points. We take the acromion process and the oligocrenon process and make a line joining these two. And at the midpoint of that line, you measure the mid upper arm circumference. We have a special colorful tape too. This tape, the colorful tape where you see a red section, a yellow section, a green section. What is this colorful tape called? This is known as Shakir's tape. This tape is actually used as a screening tool for malnutrition. So it has 3 zones, red, yellow and green. Green means the child does not have malnutrition. The child has normal nutrition, good nutrition, appropriate nutrition. This is when the mid upper arm circumference is more than 13.5 centimeters. Then comes the yellow zone. This yellow zone is in between 11.5 to 12.5 centimeters. Right? And then we have red zone. That is less than 11.5 centimeters. This is the red zone. So this tells me that the child has severe malnutrition. So this is how you interpret the findings of the Shakir's tape. Now let's move down to the next important staging that we read in growth and development. So we all know puberty means appearance of secondary sexual characters. This appearance of secondary sexual characters is rated by sexual maturity rating, that is also known as Tanner staging. We have Tanner staging for males, we have Tanner staging for females. So firstly, let's understand the Tanner staging for males. So it is very easy to remember. We have stage 1 to 5 as you can see over here. Stage 1 is going to be the pre-adolescent stage. That means infantile features would be seen, no sexual growth would be seen. So stage 1 is typically pre-adolescent, and stage 5 would be adult like. Stage 4 is very similar to adult like, but no hair on medial thigh, no pubic hair on medial thigh. So, okay, stage 1, pre-adolescent. Stage 2, now what all feature you are going to see? You can see very sparse pubic hair. So, we have very sparse pubic hair. Then these pubic hair begin to coarsen, curl, and penile length would increase. Thereafter, penile girth would increase. Right, so firstly there will be increase in the penile length and then penile girth. And also remember, 4 ml is the cutoff for beginning of puberty. If the testis size is less than 4 ml, it is considered pre-adolescent. Once 4 ml mark is reached, we say that now the stage 2 has happened, the child is entering into the adolescent stage. Right, so this for the measuring of the testis size, we have this device known as orchidometer. You can compare the size of the testes with these beads, which represents the volume in ml. Another question that they ask about is growth spurt, that at what stage growth spurt happens. So growth spurt in males happen in SMR or Tanner staging 4. This, right, growth spurt happens in stage 4. With that, let's now move to the Tanner staging in females. Again, we have 5 stages, stage 1 to 5. Stage 1 is the pre-adolescent stage, and stage 5 is the adult stage, where you see the typical pattern where pubic hair are present on the medial thigh also. And in 4th, there will be no hair on the medial thigh. In stage 2, what will happen? Now the breast bud would appear. Can you see the formation of the breast bud? And very sparse pubic hair. In stage 3, now proper breasts are developing. There is formation of the secondary mound and the pubic hair begin to coarsen up. And stage 4, you all know. So here again they ask, when does the growth spurt happens in females, in which stage? Remember, in males it was stage 4, but in females it's stage 3. Stage 3. Right? So with that, we complete the section of growth. Now let's move to development part. A very important section, because milestone is one question that the examiner would never miss. Here and there, they will either ask you a factual point, that like when this milestone happens and the child is able to do this, what other milestone will be present at that age, or they're going to test a conceptual question regarding the laws of development. Right? So let's start with the images that we encounter in development part. So before we go into development, growth assessment is very quantitative assessment, right? You take a machine, take the weight, you take machines like infantometer, stadiometer, measure the length, height, you take tapes, measure the HC, everything has a number to it, right? It's quantitative. But the problem with development is that it is a qualitative process. It depends upon the maturation of CNS. So we have to do different maneuvers to assess that quality. So 3 maneuvers I want to discuss over here, because 3 types of pictures you are going to encounter in your exam. So I have 3 maneuvers. First maneuver is this vertical suspension, where I lift up the baby like this. Second maneuver is ventral suspension, where I lift up the baby with the abdomen in the air. It's like Ulta Bahubali, right? You have seen Bahubali, right? In Bahubali, Bahubali was raised up with back on the support of hands. But here we have Ulta Bahubali. Stomach is at the support of hands. This is ventral suspension. And the third is to check the infant health control, pull to sit maneuver. You make the child lie down, Hold the hands and make him sit. This is pull to sit maneuver. So what exactly I am testing over here? So in all of these maneuvers, you are actually testing the head control of the child. We all know that the direction of progression of development is cephalocaudal in direction. So head control will come first when the child is very small, newborn. Then this head control will be absent. As the child approaches the 3 months cutoff when head control establishes, you will notice that the child is able to hold his head. So I want you to remember these three terms. First is pull to sit. In pull to sit, remember 4 weeks, 3 months, 4 months. So let's go to pull to sit first. I told you, remember 4 weeks, 3 months, 4 months. So at 4 weeks, what do you see over here? When I pull the child up, there is no head control. The head is lagging behind. This is definitely before 3 months of age. This you see at 4 weeks. Then comes 3 months landmark, when the child gains the control. So can you see now, when I am lifting up the child, the head is in line with the body. The head control is achieved. And then comes the 4 months landmark, when I'm making the child to sit, when I'm pulling the child to sit, he's actually helping me to make him sit. He's lifting off his trunk too. This is at 4 months. 3 months have now crossed. So remember, 4 weeks, 3 months, 4 months. 4 weeks, complete head leg down. 3 months, head would be in line with the body. And at 4 months, the child will now help you to make him sit. Now let's talk about the second maneuver, that is this maneuver, ventral suspension. Here also I want you to remember three terms: 4 weeks, 2 months, 3 months. Now let's see the ventral suspension. So in ventral suspension, what happens? When the child is completely lagging like this is 4 weeks. When you notice that the child is now lifting the head in one line, this is 2 months. When the head is now above the plane, that means the complete head control has happened. That's 3 months, right? So remember, 4 weeks, 2 months, 3 months. Now let's move to the last maneuver, that is the prone position. When the child is lying down in a prone position, the child is born and the flexor tone is predominant. So when a newborn child is born like this, you will notice that the thighs are flexed, the pelvis is high up. Then we have this image where you can see now the pelvis is lying flat. Pelvis is lying flat, thighs are now extended. Then the child begins to hold his head up, and finally the child is also able to lift his chest up. So this is nothing but prone position. Here remember 2, 6, 8, 3. So at 2 weeks, the child would be like this, pelvis high up, thighs flexed. 6 weeks, you see that now the pelvis is lying flat, the thighs have extended. 8 weeks, now the child will be able to lift up a little of his head. And lastly, at 3 months, the child will now also be lifting off his chest. So these are the maneuvers in the prone position. Now let's see some other milestone. Look at this. How the child is sitting? The child is sitting with the support of his hands. This is known as tripod position. Tripod position. This is sitting with the support. The child is taking the support of his arms and then sitting. This comes at 6 months of age. Whereas, look at this child. This child is sitting without any support. This comes at 8 months of age. Two important milestones, sitting milestones. Sitting with support comes at 6 months. Without support comes at 8 months. Then look at this. Now this child is moving here and there on all of his 4 limbs. In the first image, the abdomen is touching the ground. And in the second image, the abdomen is lifted off the ground. So when the abdomen is touching the ground, this is known as crawling. And when the abdomen is lifted off the ground, this is known as creeping. When does crawling comes and when does creeping comes? Crawling comes first at 8 months and creeping comes later on at 10 months. So these again important milestones, crawling and creeping. Now let's see this, what this child is doing. Looking in the mirror and playing with the own reflection. This is known as mirror play. This mirror play is a very important milestone. When this comes at 6 months of age. How do you remember that? The child is looking himself or herself in the mirror and finding themselves sexy. So S for sexy, S for 6, I remember it that way. So at 6 months of age, the child would be able to play with the image that the child sees in the mirror. This is known as mirror play. Now look at this. What is this? The child is holding something in between the thumb and index finger and is supported by middle finger too. This is nothing but pincer grasp, and this pincer grasp is an immature pincer grasp because the child is using accessory fingers too. If the child would have used only the index finger and the thumb, this is known as mature pincer grasp. So wherever you see an OK sign, that is a mature pincer grasp. If other fingers are used, this is immature pincer grasp. So firstly comes the immature pincer grasp. Firstly comes the immature pincer grasp. This comes at 9 months of age. And the mature pincer grasp comes by 12 months of age. Right? Now look at this. Two another milestones. In the first, the child is standing with support. And the child might move also by holding that furniture, which is known as cruising. So standing with support comes at 9 months, whereas cruising comes at 10 months. But look at this girl child. She's standing without any support. The standing without any support comes at 12 months of age. So remember, on the first birthday, the child will be standing independently and cutting the cake. Right? So stand without support comes at 12 months. With support comes at 9 months. Now look at this. This child is independently walking. This child is walking with hand held. So walking with hand held comes at 12 months. And independently walking comes at 15 months. At 18 months, this child would be actually running. Right? So walking with support, with hand held, comes at 12 months. 15 months, the child would be walking independently, and at 18 months, the child would be running. So these are some important milestones that we covered. Now let's move to a beautiful section of nutrition. In nutrition, important is your breastfeeding, breast milk, malnutrition, extreme forms of malnutrition like kwashiorkor, marasmus, SAM is an important topic, and also particular vitamin deficiencies. So without further ado, let's start. Firstly, in breastfeeding, it's important that you identify what is good attachment, what is poor attachment. So what are the signs of good attachment? The child's mouth, firstly, the latching position. It should be wide open, mouth should be wide open, lower lip should be everted, right? Child's nose should be free, chin should be touching the breast. This is the ideal latching position, good latching position, right? If the attachment is good, the output would be better. It would be a pleasant experience for the baby as well as the mother. Otherwise, it is going to be painful for the mother, and also baby won't be getting enough milk output. So very important signs of good attachment and good positioning. Then comes milk. I can see two types of milk over here. This is breast milk only. We have A and B. But you can see the A milk looks more white, more watery, whereas B milk looks quite yellow, right? So this is because we have something known as hind milk, something known as fore milk. So firstly, fore milk is expressed. This fore milk is more watery, the first half of feeding, foremilk is expressed, which is more watery. It is meant to satisfy the thirst of the baby. On the other hand, B section, it is hind milk. It is expressed later half of the feeding session. This is more fatty. It is meant to provide satiety to the baby. Right? So remember, foremilk and hind milk. Now moving to vitamin deficiencies and their manifestations. Can you see over here in this child? I see a particular dermatitis like rash, a typical necklace like pattern. This is known as Casal's necklace. This you notice in the sun exposed areas. Seen due to which vitamin deficiency? Due to niacin deficiency. It is a part of the 3D disease, that is pellagra. Dermatitis, diarrhea, death. Right? Diarrheas, dermatitis, dementia, death. Right? So niacin, very important. Remember, a child who is having jowar based or maize based diet can develop this. Heart nerve disease, where there is decreased absorption of tryptophan, you can see this. Carcinoid syndrome, where all the tryptophan is used up in the formation of serotonin and no niacin is formed, again you can see this. Also in B6 deficiency, which is very important for kynurenine pathway, you can again manifest this. So this is nothing but pellagra 3D disease. Now look at this. I can see some conjunctivitis, beefy red tongue, also new vascularization. There is perioral redness also. What is this? This is nothing but your B2 riboflavin deficiency. Riboflavin deficiency. Then comes these two babies, age-old picture, baby A, baby B. Look at the baby A. No fat whatsoever, skin and bones baby, just a skin and bones baby. This baby is looking very alert. If you offer food to this child will have a very voracious appetite. For example, a child with this particular age, if I offer him food, he might take 1 chapati, 2 chapati. But this child has very voracious appetite. He might eat 7 chapatis, 8 chapatis, 10 chapatis, very voracious appetite. Because of this voracious appetite, this child will recover better, right? So the prognosis here is going to be good. On the other hand, look at the child B. Swollen up, looks fat, right? So this baby is known as fat sugar baby. This baby is actually edematous. That's why looking fat. And can you see how he's lying listlessly on the floor? He's not alert at all. His appetite is also lost. If you offer food to this child won't be able to have much. So the prognosis here is poor. Which baby is a marasmus child? Which baby is a kwashiorkor child? A baby is a marasmus child. And this is kwashiorkor. And the important differences we have already discussed till now. With that, let's see some changes that we see in these extreme forms of malnutrition. There are some skin and hair changes that you appreciate in these extreme forms of malnutrition. Can be seen in both marasmus as well as kwashiorkor, but it is more seen in patients with kwashiorkor. So let's see the first hair change. Can you see there is hypopigmentation, hyperpigmentation, hyper. What is this? This is known as flag sign. Flag sign. Then we have this image B. What is happening over here? Can you see a characteristic pattern? This is known as crazy pavement appearance. Crazy pavement appearance. And lastly, can you see this peeling of the skin that is happening? This type of dermatosis is known as flaky paint dermatosis. Flaky paint dermatosis. So these are some skin and hair changes that you appreciate in children with extreme forms of malnutrition, especially kwashiorkor. Then look at this child. What this child is having, this red and white packet. This is nothing but ready to use therapeutic food. that we use in patients of SAM. The advantages of this ready to use therapeutic food is does not require any preparation, does not require any refrigerator. This small packet only gives 500 plus calories to the child. So it's definitely a boon for areas that have low socioeconomic pattern. So remember, ready to use therapeutic food. Then particular vitamin deficiency, let's look over here. Can you see the x-ray of the child? What peculiar findings can you appreciate over here? Look at the hand and the bones. I can see cupping. The bone is now cupped. I can see splaying and fraying. So cupping, splaying, fraying. These are the typical features, and also the bone density is less. Can you notice? Bones are not looking as white as they should look on x-ray. So the bone density has also decreased. This is nothing but vitamin D deficiency known as rickets. So whenever there is vitamin D deficiency in growing bones, it is labeled as rickets. If vitamin D deficiency happens in you and me, we already have grown bones. We are not in the growing stage now. So in that case, it is known as osteomalacia. This is the typical rickets picture that you encounter in pediatrics population. Then we have this x-ray. Can you notice? The cortex is very thin, pencil thin cortex, and there is subperiosteal bleed. Right? This is periosteum, and you can see this area, this is actually bleed, subperiosteal bleed. Then we have epiphysis in the shape of ring. This is known as ring epiphysis. Can you notice this? Dense zone of provisional calcification known as white line of Frankel. At the edges of this white line of Frankel is this Pelton spur. Just below this white line of Frankel, I see an area which is black. This area is known as Trummerfeld zone or scorbutic zone. This is the typical X-ray that you see in vitamin C deficiency, scurvy. Right, so you should know identification of the x-rays of scurvy as well as rickets. With that, let's move on to the images of respiratory system. A very small component when you talk about pediatrics, an overlap between ENT as well. So let's look at these images. Look at this first image. This is the epiglottis of this child. How is this epiglottis looking? This is omega shaped epiglottis. So very lax. Because of this, what happens? This child has stridor. And as you put this child to the prone position, this stridor disappears. Because now this lax epiglottis falls forward, so the stridor disappears. This usually gets better on its own by 2 years of age. If doesn't happen, then we go for supraglottoplasty. So this is about laryngomalacia, where there is lax epiglottis. So this is nothing but laryngomalacia. Then let's talk about this next image. Can you notice the glottis now, the subglottic region has narrowed. This is known as subglottic stenosis. Subglottic stenosis. Another congenital issue which can cause stridor. Then we have two important conditions over here. Look at the image A. What do you see over here? This is the lateral neck x-ray, and I see that the epiglottis is now swollen and rounded. This is known as thumb sign. Where do you see this thumb sign? We see this thumb sign in cases of epiglottitis. Right? Epiglottitis, bacterial infection, inflammation, a very emergency like situation. You have to manage, this child is going to be very toxic. You have to ensure ABC, airway, breathing, circulation, and then give IV antibiotics. On the other hand, look at this image. Can you see narrowing of the windpipe? What is this sign known as? This is known as steeple sign. Where do you see the steeple sign? We see this in LTB, that is laryngotracheobronchitis. This child will present to you with barking cough. Just nebulization would suffice over here. This is a viral issue. You don't need to add on antibiotics. The child here would be usually non-toxic as compared to your epiglottitis child. So this is all about your respiratory system images. With that, we complete the first part of the images revision. I hope this would have triggered your brain cells to go back and recall and revise all what you have studied in your main lectures and main notes. See you in the next part. Thank you.